So the guidelines now talk about basal insulin. You initiate it, and if you're not controlled, you have a choice. You can add one rapid-acting agent with the largest meal of the day, or you can switch to pre-mix twice a day. I think that's actually less flexible. Or you can add a GLP-1 receptor agonist. So here again, John, let me ask you, how often do you make this choice, and what do people find more acceptable?
Right. It's a great point. And I love the fact these guidelines got updated about 3 years ago, because I think one of the greatest points of clinical inertia is that period between, we got pretty good about giving basal insulin and titrating basal insulin, but we still were very poor about when to go to that postprandial component. And I know that in the primary care world, the idea of initiating a basal plus 1, 2, or full basal bolus insulin therapy requires numeracy on part of the patient, a tremendous more education, more injections, weight gain, the potential for hypoglycemia. It's just much more complex than the idea of adding a twice a day, once a day, or even a once a week GLP-1 receptor agonist that has been shown, and I'm sure we'll discuss the data here in just a second, as good or better in most cases than full basal bolus therapy without all of those burdens that you just discussed.
I agree with you. And the guidelines also give you a lot of detail about how to titrate your insulin, both titrate up as well as titrating down if you get hypoglycemia, how to add prandial insulin and how to do it when you need to, and also consider the GLP-1 receptor agonist.